11:30. So thank you again, everybody, for being patient with me and my situation with my daughter. She's doing okay right now. So, and then everybody that sent me an email, thank you so much. That really meant a lot to me. But I did want to be able to at least go over some stuff with you guys. So I was thinking we could go ahead and just do the practice test together, practice exam 3. Full disclosure, I have not seen it yet, so I don't know all the answers. I think you guys have probably gone through it, but I will do my very best. So let me pull it up. Okay, so this is what it looks like for me. I have to go in it as to preview the exam, but when we click on things, it will tell us whether or not it's correct. So we have a client with osteoarthritis. What medication do we think that they will be prescribed? Any guesses? I'm gonna go for this one. Oh, and that was incorrect. So Tylenol, they would start this one. They would not give NSAID. So cyclobenzaprine is a muscle relaxant, so we wouldn't get that, and then we want to avoid NSAID. So we want to just give Tylenol. Okay. Nurse is testing a client with diabetes insipidus. Which of the following findings should the nurse expect? Brandon, is B for this one, or was that for the last one? Brandon thinks A. And that is correct. So specific gravity, if we're looking at below 1.005, then that is going to be diluted. And so in diabetes insipidus, if you remember, the urine does become very diluted and we get copious amounts of it. And then we wouldn't expect bounding peripheral pulses. We're going to expect them to be losing quite a bit of fluid, and so we would expect weak pulses. We're expecting tachycardia. So tachycardia is our body's response whenever we're losing a lot of fluid to help make up for that lost circulation. And then we're going to expect the opposite of moist mucous membranes because we're expecting them to become dehydrated. Okay, what's the difference between a plaster cast and a synthetic cast? Which of the following information should we include in our teaching? Patrick thinks B. And that is correct. So really, plaster casting, in my experience, we don't really do in the ER. That would, I think, be more like a outpatient orthopedic basis where a synthetic cast, we can go ahead and splint it, or we can put like an air cast or some kind of immobilizer like that until they can go see the orthopedist. So plaster cast is a lot messier and it's a lot heavier for sure. Okay, we have multiple fractures on our left leg. It's causing edema. And then what would be recognized as an early manifestation of complication? Chanel says B. Yeah. So breaking down the question, we've got multiple fractures in a leg and there's edema. So these are your clues that they're looking for compartment syndrome because that's a recipe for compartment syndrome, right? Okay, a nurse is working for a home health agency. Okay, so what hemoglobin A1C level are we looking for that things are appropriately controlled? A, yeah, exactly. So we want under 7, and really they're going for 6.5 or less. Usually, if it's under 7, we're good, but they walked it down even further. So 6.3 is in the range where we know that over time that their blood sugar has been controlled. Because instead of our finger stick blood glucose, which shows us just a snapshot in time, our hemoglobin A1C is showing us a long period of time. So not just what their blood sugar is that day, that moment, but how it's been controlled over time. So that's why it's useful, and that's why it's used in outpatient management for diabetes. Okay, an unrepaired femur fracture, okay. What are we going to do when we are assessing the neurovascular status? D, okay. And that is correct. So the components of our neurovascular exam, good job, Haley, is our skin color. So is it pale or does it look pink and nicely circulated too? Is it cold or is it nice and warm? Oh, you can't see the questions? Can anybody see them? Sometimes it does glitch. You can see? Okay. So I want to just like go out and then come back in this session. Sometimes Blackboard just is a pain. Okay. The sensation, can they feel or not? And then are they having any pain? And then our cap refill in our toes, we're going to press on the toe and look for a brisk return of the color. So we're going to press it down, it's going to turn white, and then we want to see within about 2 seconds a return of the color. Okay, we are reviewing guidelines to prevent DKA when our type 1 diabetes patient is ill. What do we want to include in our teaching? I'm assuming B is good, so that is correct. Yeah, so when our diabetes patients, are ill and in the hospital, a lot of times, even if it's a type 2 diabetic, we might have to put them on insulin because the body just needs that extra help when they're sick. It's really hard to regulate the blood sugar. So when they're ill, we want them to be monitoring their urine for ketones. That tells us that they're not processing the sugar and that their sugar's high. They're going into ketosis. And so if their sugars are over 240 when they're sick, then we want them to be checking for ketones so that we can catch it sooner rather than later. Okay, patient just had spinal anesthesia, which of the following findings indicates the client is experiencing complication of the anesthesia. Couple guesses for B. Couple guesses for C. Actually, let me see. I'll put B, it's C. So that makes totally sense. So numbness in the legs is expected. And so when we have a spinal anesthesia, we're expecting the patient to be numb from like the hips down, basically. Oh, yes, it is. We started recording at 7:30, so if you missed the beginning, you can go back and watch. Headache is telling us that we might have a leak in the spinal fluid, and so this actually can happen days after the surgery as well. So we want to be monitoring for a headache in our patients that have had an access to their spinal area, so like a lumbar puncture or spinal anesthesia, we want to monitor for headache. And then they might not be able to feel the urge to void because the spinal anesthesia has numbed them, like I said, kind of from the waist down. So that would be an expected finding. Okay, we have a fractured tibia. What should we do first? So all of these might be a good idea, but if we have to only pick one, what do we want to do? Yeah, that's what I would do. Let's see if they agree. Yeah, so all these are good interventions, but we think about airway, breathing, circulation, we're going to check our circulation. So we can talk about CAS care whenever. Managing their pain is important, but we can put it off. If they're going to not have circulation in their leg, that's more of an issue than if they're in pain. And range of motion, that's a good idea, but that's not what we want to do right this minute. It's not our first priority. So good job. Okay, we have a client that has cystitis. Which of the following interventions do we want to include in our care plan? What do you guys think? Yeah, that's what I think. Oh, I'm sorry. I think that is a good instruction, but they want them to drink 2 to 3 fluids. And when I read this, I thought it said drink carbonated beverages. So that's why you got to read the whole question carefully, right? So yeah, we don't want them to drink carbonated beverages. It's irritating, and then also it's not hydrating as water. So like I always drink diet soda, and I need to drink water instead, but I don't. So, but if you want to be hydrated, you want to be drinking water. I thought 1 liter sounded good, but they want 2 to 3 liters. Okay, so we have recurrent kidney stones. They're going to have an IV pyelogram. Which of the following statements by the client should the nurse report to the provider? Okay, so which one of these is showing us an unexpected finding or something that we think is concerning? I don't know if I can zoom in because this is my window. Ooh, maybe I can. Does that help? Okay, table side D. Yeah, okay, for sure. So intravenous pyelogram, that means they're going to get contrast. Oh, cool, Janelle. Okay. We got this, teamwork. So yeah, shellfish is indicative of an iodine allergy. So if patients say they're allergic to iodine, they're allergic to shellfish, it does. It totally makes the dream work. Then we're going to be concerned about giving them contrast. So they say, I don't eat shellfish, we got a problem because they're not going to be able to get IV contrast. Okay, we have early osteoarthritis. Which of the following manifestations should we expect? Can I see for this one? See? So weight loss is manifestation of rheumatoid arthritis. So the osteoarthritis, they're going to see pain with activity, and then they're going to feel better with rest. The other choices are really rheumatoid arthritis. And then this is, so ulnar deviation, changes in the joints, weight loss, and symmetric joints being affected, we're going to associate with rheumatoid arthritis. And we're going to remember that in osteoarthritis, we're going to have pain with activity and then relief with rest. It's okay. I haven't seen it either. I'm guessing some of these. Okay, we have a leg cast, they had a fracture. If the cast is too tight, what are we going to expect to observe first? So at some point we might see all of these. Which one do we think would be the first symptom that the cast is too tight? B. I think so. A couple votes for B, a couple for C. Maybe D. Let's just go with, oh, B got the most votes. We'll go with B. B is right. So that makes sense when we start to see the toes change in color. So this is one of our neurovascular assessments, right? We're looking for the color. So it kind of makes sense that as the blood vessels are compressed, then we're going to start, the first thing that we would see is pallor. So if you think about when we press down to check for cap refill, we see that pallor for a minute. So maybe think of that to remember. That would be the first thing that we see. After a while, with less blood flow, we're going to see the temperature decrease. This edema will be eventual as well, because we said, remember that we might see all of these. It's asking us which one's first. So as the compression continues, we see edema of the toes. And then as it progresses more, then they're not going to be able to move their toes. So pallor is our first sign. We're teaching about cranberry juice. What do we want to include? Yeah, that's what I'm thinking. So cranberry juice, pretty much common knowledge, right? Not just medical knowledge, that cranberry juice is related to UTIs, that we can try to prevent them. There's even cranberry pills that you can take. And so it's going to help the bacteria not be adhering to the urinary tract. So hopefully preventing reinfection over time. Okay, what is a risk factor for metabolic syndrome? Vote for B, vote for D. I'm gonna vote for D. Oh, B was right. That makes sense. Except this says it's also a risk factor. This is confusing. Somebody else emailed me about hyperglycemia. Okay, that's what I was thinking. And then I thought, well, maybe hypoglycemia also. Okay, hypertension, that makes sense. Hyperglycemia. Asthma is not going to be related to metabolic issues. And then central obesity. So whenever you see somebody with that large abdomen, a friend of mine used to call those type of people candy apples, candy apple shape. So where they're like very round in the midsection, and then the legs are not overly thick, and they just carry that weight right around the middle. That's definitely a risk factor for cardiac disease, diabetes, and metabolic syndrome. Okay, we have a client, they have type 1 diabetes. We're going to teach them how to give themselves insulin. Which of the following should we include in our instructions? Yeah. Have you guys done your checkoff on insulin already? I'll lose track of where you guys are at in skills. Okay, so you know that we don't need to keep it in the fridge. So that way, yeah, Michelle.
I have a question. So I think I read in our book that you have to alternate sites when you're giving insulin, but then I had a flashcard that said that you do not need to rotate sites, something because like the tissue gets used to where the injection site is. I was confused. Could you kind of clarify that? Like, should you rotate sites?
I've always been told to rotate the site because you don't want to overuse one site. And even if it's like, okay, I want to do the abdomen, you're going to rotate around in the abdomen. Patrick, did you see something else?
Yeah, so I saw that same like flashcard, and I actually looked it up like because I was confused as well, and it was just saying that you want to rotate sites around like one location, so like rotate around the abdomen, because the card questioned rotating between arm, leg, abdomen each time, and so it's saying to stay with one like location but change the site in that location. So like rotate around the abdomen, not rotate like arm, leg, abdomen, arm, leg, abdomen.
I got you. Yeah, different sites are going to metabolize different time periods. So that way you're getting a more consistent response to your insulin if you stay in the same subcutaneous area. So I could see wanting to do that. But you don't always want to poke in the same exact place. So like rotating arms, like arm to arm or around the abdomen, that would work. Yeah. That makes sense. Okay, so we don't want to pull back. We don't massage injection sites. This one was pretty easy. We're definitely not going to reuse our syringes. So storing the insulin at room temperature will make it a little bit less painful. And then we're going to keep the ones that we haven't used. And just to be like full disclosure, whenever we have multi-use vials of insulin in the hospital, we are going to keep them in the fridge to preserve them. But this is for home care. So the one that they're using, they can keep it room temperature because it's for them and they're going to go through it quick enough. But just because we don't know exactly how much of the insulin bottle we're going to use in the hospital, we're going to preserve it by putting it in the fridge. Okay, we have an NG tube to wall section. Which of the following interventions do we want to include in post-op care? So what do we want to do? Patient just had surgery and they have an NG tube. I'm going to go ahead and pick some things. Oh, I think I did this earlier too. I was looking at this one. So we definitely want to turn off suction when we assess for peristalsis. So basically this is asking us, or it's saying that when we're going to assess for bowel sounds, we're going to turn the suction off because we need to be able to actually hear the vowel sounds. I didn't pick this one because we don't irrigate NG tubes with saline. We'll go with it. I guess we could, but you're just going to use tap water to irrigate unless you have some sort of order. So I hate to disagree with ATI, but we'll just go with it. That irrigating it will ensure patency, which is true. So if we're not putting things through it like a tube feed, or even if we are, we do want to flush it every now and again to keep it patent. Also, after surgery, we want to have SCDs on our patient. We want to help prevent blood clots. We want to reposition them side to side. So if they just had surgery, they may or may not be able to move themselves very well. It sounds like an abdominal surgery, probably painful. So at the least, we need to assist them in repositioning every 2 hours. And then, oh, this is what I did wrong. Did you guys see something in your reading about irrigating with normal saline? I'm not familiar with that at all. And then we want to do our IS every 1 hour while they're awake. So while they're sleeping, that's okay. They don't have to do it. We don't need to wake them up to do it, but they need to do it every hour while they're awake. Okay, we're talking to our patient about hormone therapy. Okay, we don't want to give, so basically the question is asking us, which of the following conditions are a contraindication for hormone therapy? So dermatitis, breast cancer, COPD, or GERD. Which one sounds like a bad idea? Exactly. Yep. So history of breast cancer. So breaking this down a little bit more, if you're not sure, for like, oh my gosh, I totally can't remember. Which of these things is actually related to hormones? Well, dermatitis, no, that's fine. COPD, that's a respiratory problem. GERD, that's a digestive problem. So if you find yourself in a question like this where you're like, oh, I really don't know, try to break it down that way. Like, which one of these choices is actually related to what it's asking me? Okay, we have an acute exacerbation of ulcerative colitis. What do we want to do first? So all these might be a good idea. Which one do we want to do first? Michelle, let's see. Okay. Oh, D. B. Wait. Okay. I'm giving votes for B. So I would have picked A. So if you think about it, you can only pick one. Which of these things, if we don't do it, could be the worst? So electrolytes out of balance, not intact perianal skin, having an emotional concern, or what did they eat? So of all those things, the most dangerous thing is going to be electrolyte values out of whack, right? Because when we have potassium out of whack, we can start having heart dysrhythmias. So of those choices, all of them are good things to do. We're a good nurse, and we're going to do all of them. But the one we want to do first, address first, is the electrolytes. Hopefully that makes sense. Okay, we have painful burning feet. What do we want to do? I'm going to kind of speed some lines along. So we want to put a bed cradle. Basically, we want to support the feet so that nothing's touching them. Our diabetic patients, their feet can be really, really painful. My mother-in-law has diabetic, or not diabetic, she has neuropathy in her feet from chemo, and my dog's like always managed to step on her feet. And so she likes nothing to touch her feet. So that's how I remember that. We have a new diagnosis of urge incontinence. What do we want to teach our client? There's a lot of choices here. B, C, D. Okay. So, yes, I was going to pick this one. So anticholinergic medications are going to suppress the bladder contractions, so suppress that urge incontinence. So if we remember, urge incontinence is when they feel the urge to urinate and they can't necessarily control that. So it's like they got to go and it just comes out. So the anticholinergic medications can help with that. It's a good idea to limit fluids in the evening. If there's less in there, there's less to come out, right? We don't want them drinking caffeine because like we talked about before, so in everything urinary, caffeinated beverages are going to be irritating to the urinary tract, basically. So it's going to become irritating to the bladder, and so we don't want them doing caffeinated beverages either. We don't really do intermittent urinary catheterization for urge incontinence. That would be when they are like retaining urine. So would not necessarily do that. And then we wouldn't be thinking of an anterior vaginal repair. That would be for stress incontinence. So like after women have had a lot of children, sometimes they need a repair for the bladder because everything is too lax, and then they're not able under stress. So jumping, coughing, laughing, sneezing, all those things, the muscle tone is not there anymore to hold the urine in, and they can have an escape of urine. So the vaginal repair would be for that. Okay, we're talking about the difference between skeletal and skin traction. So again, break these questions down a little bit more. It's a fancy way, like I've told most of you guys, like I write questions and it gets really boring to write the exact point every time. So in this situation, we're teaching. And so the real question is, which of the following statements is true? Okay. And we're getting lots of C, and that's correct. So skeletal traction makes sense. We have a fracture. Skin traction can decrease muscle spasms, but it's more appropriate to do skeletal traction for the fracture. Makes total sense. Okay. Man, we got a lot of leftover replies. Okay. We want to reduce the risk of diabetes. Again, which of the following is true about diabetes? What do we want our diabetic patient to do to reduce risk? AC, I agree. What about this one? What about E? I'm gonna click it. So reducing cholesterol, saturated fat. So we are concerned in our diabetic patients, one of our complications is going to be, this is putting them at risk for heart disease. So we want to basically do are modifiable risk factors for coronary artery disease. So we want to reduce cholesterol and saturated fat, increase physical activity, daily exercise. We want them to stop smoking. Sustaining hyperglycemia is the opposite of what we're trying to do in diabetes control. And then we want to maintain optimal blood pressure. So kidney damage is another thing that we're concerned about in our diabetic patients over time. So the blood pressure, it's also going to help our coronary status, right? So that's something that they need to do to help protect their kidneys. Okay, foot care. What do we teach type 1 diabetics about foot care? What do you guys think? Yeah. Sandals in warm weather, that sounds like they're going to be having friction in between the toes, which could cause skin injury. Sounds like a bad idea. We don't want to put lotion in between the toes because we're going to get bacteria. It's going to stay too moist. We want to check the feet every day for sores and bruises because something that starts out really small can become a gangrenous toe. So they might not feel it because of that diabetic neuropathy when it happens. So that we need to make sure that they're checking. I had a patient one time that stepped on a nail and because of diabetic neuropathy did not feel it. So they had a nail in their shoe for like an extended period of time. So that's how numb the feet can be. And we don't really want to put their feet in cold water. We want to use warm soapy water, just like we always do to wash our hands. Makes sense. Okay, diabetic, they're self-monitoring, they're type 1 diabetic. Which one of these statements shows that they understand how they're going to take care of themselves at home? C and an A. Let's try C. So we're going to check urine for ketones when the patient is sick, like in our previous question, if you guys remember. If they're having high sugar and they're sick, we're going to want them to check for ketones, or not necessarily sick, but if they start having high blood sugar readings, we need to know if they have ketones in their urine. We don't need to notify if it's 120. Checking blood glucose every 4 hours while they're sick, that's a good idea because normally they would just check it before meals and at bedtime. So this is going to let them have a little bit more monitoring when we're more concerned about their sugar being out of range. And then when they're lightheaded, we are going to do like every 15 minutes. So all of your, hypoglycemia protocols, there we go. You're going to give your intervention and then you're going to recheck in 15 minutes because 5 minutes isn't enough when they've eaten something or taken a juice. 5 minutes isn't going to be long enough for that to take effect, okay? So, not that one. Okay, we have postoperative ileus and NG tube has drained, oh dang, 2,500 in the past 6 hours. What are we concerned about? That's a lot of fluid. That's like over a 2-liter bottle of soda. I'm gonna guess this. So we're concerned whenever we're losing fluids from diarrhea or vomiting. In this case, it's the NG tube is pulling the stomach contents out. The electrolyte that we're worried the most about is potassium. Okay. What do we want to teach diabetic clients about exercise? I'm thinking B, yeah. So when we do exercise, when diabetics do exercise, that drives blood sugar down. So we don't want them doing that when they're already like borderline hypoglycemic. Let's see, ketones, just like everybody else, whenever we are exercising, that can increase ketone production. So if there's already ketones present, that's not good, and we are putting them at higher risk for hyperglycemia. Definitely a good idea to eat before exercise, because again, we don't want them going into it hypoglycemic. And then we know we don't examine our feet weekly. We examine our feet every day, so we can rule this out right away. Okay, why did I develop diabetes in a type 2 diabetic patient? So again, to rephrase it, what is a risk factor for developing type 2 diabetes? Yeah, exactly. So the body has insulin resistance and decreased insulin secretion. So over time, the body is less responsive to the insulin that is produced in the body, and less insulin is being produced. And then we have type 2 diabetes. The client is lying in bed sweating and feels anxious. Uh-oh, what do we think is happening? Okay, good. I was gonna say, everybody please say A. Exactly. So pretty easy question, I hope. They've got you with the type 1 diabetes, okay? Sweating, anxious, hypoglycemia, like gold standard. Anytime our patient's sweating, feeling anxious, we want to check their blood sugar. Okay, the patient has interstitial cystitis. What findings are we going to expect? This one's pretty easy too, hopefully. So interstitial cystitis, we're gonna have bladder infection. What do we think would be a finding in a patient with a bladder infection? Yes, exactly. Oh, I lied. So we wanted negative urine culture. I would have guessed fever for D, yeah. So interstitial cystitis is non-infectious. Fracture of the forearm, screen stick fracture. What do we want to tell them about it? Okay. So we don't necessarily want a negative result. They're saying that you might have a negative urine culture in a patient with interstitial cystitis because it's a non-infectious process. That one threw me off too. I was thinking fever. A for this one, yeah, I think that's right. So green stick fracture, fragments of bone have splintered in the surrounding tissue would be a comminuted fracture. Bone ends forced each other is an impacted fracture. Sharp edge of the bone has broken through the skin is a compound fracture. So pretty easy to guess, I think. This one could be, you think about a stick breaking, a green stick, so like a really bendable stick. When it breaks, part of it's still together and then part of it is broken. So that is what that looks like in children, because their bones are still pretty bendy. Okay, we've got blood gases. What would we expect for a patient who has acute kidney injury? is A, D, D. Yeah, that's what I was thinking. So what we're seeing right here is metabolic acidosis. So we're having an injury to our kidneys, and our kidneys in this whole acid-base balance equation are going to be producing bicarb to help regulate the acid-base balance in the body. So our bicarb in this scenario is only 14, which is too low, which shows that the kidneys are not producing enough. This has driven our pH down, so we're acidic, and our CO2 is normal, or actually it's a little bit low. So we know that our acidosis is not respiratory because our CO2 is not high. If we had a low pH and we had a high CO2, we would have respiratory acidosis. So in acute kidney injury, we're expecting a metabolic acidosis because they're not producing the bicarb acetation. Which of the following findings? Okay, what is a risk factor for osteoporosis? What do you guys think? B. Yeah. So when we talked about alcoholic beverages, pretty much any process that we're talking about, you start to get 2 to 3 or more drinks a day. That's the problem. 1 drink a day is not a problem. A pack of cigarettes, on the other hand, is a problem for a lot of things, and we know that smoking is a risk factor for osteoporosis. We would expect a small body stature as a risk factor. Bone fracture during childhood is somewhat normal, right? Just from accidents. But if we're having bone fractures in older age due to osteoporosis, that would be a risk factor, not a childhood fracture. Okay, we have a patient with SIADH. We want to know which of the following conditions is a risk factor for SIADH. I guess this would be, and that is correct. The treatments that they've taken for that can cause secretion of antidiuretic hormone, which can result in SIADH. So this is one of those things that's a little bit complicated, kind of like the thyroid when we're thinking it's opposite. So when we're having too much antidiuretic hormone, an antidiuretic hormone is going to keep you from urinating. So when we have too much of it, we're going to retain our urine and have the issues that come with that. Okay, our patient has uncontrolled diabetes. What are we going to expect to find? Vote for C. Okay, let's see. So weight loss. So you would expect to see hypotension, hematuria. So there's really no reason for blood to be in our urine. If it said ketones in the urine, then that would be something we'd be looking for. And uncontrolled diabetes, right? Tachycardia would be the finding that we would expect. And then weight loss makes sense. Okay, the patient had a total abdominal hysterectomy. They had bilateral salpingo-oophorectomy for uterine cancer. Which of the following instructions should the nurse include in the teaching? Is B for this one? B. That is correct. So when we don't have a cervix anymore, so when we're taking a total abdominal hysterectomy, we're taking the cervix. There's nothing to test on a pap test. Okay, so patients that have had a hysterectomy no longer have to have a pap test. We have taken the ovaries, and so we are going to have less estrogen being produced. The uterus and the ovaries are gone. So again, when we talked in our class about all the changes that happen with our hormones and all the things that happen when we start losing estrogen in females as age progresses, we talked about how we can start to have vaginal dryness as one of the symptoms of low estrogen, right? So that connects, that makes sense. We don't want to see drainage after the surgery. It can be a sign of complication. 2 to 3 weeks, so just like after a pregnancy, we're going to want them to wait at least 4 to 6 weeks to resume sexual intercourse, because that the body just needs that much time to heal. Okay, the patient had a thyroidectomy. They're reporting severe muscle spasms in the lower extremities. What do we want to do? You guys think? Couple for A. I'm gonna go with B. So we could check the fetal pulses, but what this is triggering you is that, so thyroid and calcium kind of play in together, right? And calcium and muscle spasms are also connected when our calcium is too low. So it wanted you to recognize that we had a thyroid surgery, which is connected to calcium, and muscle spasms are related to hypocalcemia. And it may be as simple as replacing the calcium, but you could also give a muscle relaxant if they're really uncomfortable. Potassium is really not related to spasms, it's related to leg cramps. So if the Q would have been they have leg cramps, we would have been more concerned about potassium. Let's see, we have a fracture. What's the highest priority to achieve functional healing in a patient with a fracture? Yeah, I'm gonna go with A. So when we talked about fractures together on our system disorder, so the main goal of our fracture patient is that we want to keep the bone realigned, and we want to keep it immobile. So we want to keep it aligned and in place until that can heal, and then we can take things off. So if you don't remember anything else about fractures, just remember we want to keep it in the correct place and immobilized. Okay. Have a client with BPH. What are we going to expect? Yeah, Emily, I'm thinking C. Yeah. So in BPH, we have that prostate is really inflamed. Well, not inflamed, but larger than usual. So if you're ever trying to place a Foley in a patient with BPH, it's really hard to pass that through because that prostate kind of blocks that. Same thing with them trying to urinate. Sometimes it's hard to get that started, get enough pressure within the urinary tract to get that bladder or get the urine flowing. And then PSA level, it's something that you think might be related to BPH because we have the prostate enlarged, but the PSA level is really supposed to be specific to prostate cancer. So that level should be drawn to check for prostate cancer. It's not really related to BPH. Okay. Pyelonephritis. What do we want to teach about pyelonephritis? Okay, Lindsay, for this one, or was that for the last one? This is B. Couple. Okay, so pyelonephritis, so it's not going to be the lower urinary tract. This is where our urinary tract infection has actually gotten so complicated. It's gone up within the urinary tract and now it's affecting the kidneys. It's usually caused by E. coli. So most urinary tract infections are going to be caused by E. coli. If you think about it, that bacteria is just kind of naturally present in that area and it can become overgrown. It's definitely going to cause symptoms. You're going to have patients become really, really ill with high fever. They're going to come in just feeling terrible, nausea, vomiting, also reporting flank pain. So those kidneys have become inflamed. That causes, whenever you hear flank pain, think kidneys. Those kidneys are just really inflamed and painful. So whenever we have a pregnant woman, so whenever the moms go in for their periodic checks, depending on what period they are in their pregnancy, always check for urinary tract infection in the dip, right? Because the urinary tract infections can cause preterm labor, and especially if it gets to the point where it's traveled all the way up to the kidneys. So we always want to watch for that and prevent that in our pregnant patients. Okay, we have an adolescent patient. They have a fibroblast cast. Which of the following is a priority action for the nurse to take in a patient with a fibroblast cast? Yep. So again, priority action tells us all of these might be a good plan, but which one, if we can only do one, and we want to do a neurovascular assessment, that's going to be the most chance that something could be really bad with our patient. We can do discharge instructions whenever, we can provide reassurance whenever, ice pack, we can, it's going to help reduce swelling and help with pain, right? But that's not the priority. Just like in our other priority question, the patient was in pain. We do want to address that pain, but if we can only pick one, we're going to pick circulation. Okay, we have a patient high risk for osteoporosis. How are we going to increase calcium level with dietary measures? So, in other words, which of these foods is high in calcium? B, I agree. Broccoli is high in calcium. So greens are going to be good sources of calcium. Dark green vegetables. Oh, let me, oh, they took my door off. Hold on one second. My family's got back in the Okay, sorry about that. Number 43, B. Okay, let's go with B. I haven't read it yet, but. Okay, so yes, exactly. When we have dehydration, we increase the risk for renal stones. Okay. So yes, we want to always keep our patients that are at risk for renal stones to stay really hydrated. So drinking like our caffeinated beverages, like we talked about earlier, is something that we want them to avoid. We want them to drink water. I had a friend that I worked with in the ER, and she got a kidney stone, and after that she brought literally like a gallon of water and drank it every day because that's how much she didn't want to get another one. Let's see. Okay, we're going to do a DEXA screen to find out if the patient is has osteoporosis. What instructions do we want to include in the teaching about the DEXA scan? I know, Tiffany, I would too. Instead, I just keep drinking Diet Coke. Everybody thinks A. Yes, so we don't want any metal objects. So anytime you have something X-ray, removing metal objects is going to be a good guess, right? Because we don't want those in the way of the bones. They'll actually show up. So if you look at X-rays of your patients, and they have even the tele clips will show up on the X-ray. So anything metal needs to be moved out of the way so we can see. Okay, we have chronic kidney disease. What would we expect? What are the following BUN levels is indicative of chronic kidney disease? Oh, and creatinine. Yeah. Exactly. So normal creatinine is about 1, and we're seeing this patient's creatinine is 8. So that tipped me off that that was the answer, because those patients come in and their creatinine is really high. You and I live at probably like a 1 or lower, but they constantly have a really high creatinine. Yeah, Michelle.
Can you show me the question one more time, please?
Oh, sure.
Thank you.
Mm-hmm. All right. Okay, we administer desmopressin to a client that has a diagnosis of diabetes insipidus. Which of the following laboratory findings indicates a therapeutic effective medication? I'll guess for B. Guess for C. I'm also thinking C. So for diabetes insipidus, remember that we're not really thinking about our blood glucose in that instance. We're more concerned about our fluid balance. So diabetes insipidus, we are looking for the urine-specific gravity to be within the expected range. So we want to see decreased serum sodium, increased urine sodium. We're really, again, looking at our urine-specific gravity, and it shouldn't alter our blood glucose. And then our BUN, that would be normal, but it's not really going to affect the BUN. Okay, we have chronic kidney disease, and we're looking for a fluid volume increase. Which of the following provides a reliable measure of fluid retention? What do you guys think? Yeah, that's what I'm thinking. So exactly, whenever we have patients that we're concerned about fluid volume, we're going to have daily weights ordered for them. And so we're going to try to weigh them at the same time every day, usually at like 4 in the morning. And then we want to make sure, so that our weight is accurate, that we do it at the same with the same type of scale. So I'm used to weighing them in the bed because ICU patients are usually in their bed, and so when you weigh in the bed, you also have to think about, we always want the same items on the bed every single time, because if your patient's cold and got 10 warm blankets from you last night, then those blankets are going to make it look like the patient has gained weight and is too fluid overloaded. So we want to make sure that we're getting accurate weights. It's really important. Okay, we're 3 days post-op. We don't have bowel sounds. The abdomen's distended. The client is passing no flatulence. We're not passing gas. What are we concerned about? What is the complication of abdominal surgery that leads to no bowel sounds and abdominal distension? It's another way to ask the question. Yeah, exactly. So ulcerative colitis is not a surgical complication. That's a whole disease process. Cholecystitis, we're not really concerned about our gallbladder in this scenario. Paralytic ileus, on the other hand, is the hallmark signs of that are we're not going to hear bowel sounds, the abdomen starts to become distended, and then we're not hearing bowel sounds, and the client's not passing gas. So nothing's really getting through. And so the abdominal surgery is going to be the biggest risk for this. And then also, it's pointing out too, we're giving opioids, which is going to slow down the gastric process as well. So we've kind of got a 1-2 punch with the abdominal surgery and then the opioids. And this is a really common complication that you would see. And then wound dehiscence, that would be bad, but nothing in our stem is telling us that we're concerned about wound dehiscence, if that makes any sense. Okay, the client had a cystoscopy and a new prescription for tamsulosin, which is Flomax. Which of the following adverse effects are we going to include in the teaching? So what is a side effect of Flomax? D. I think it is B. So dizziness is a common side effect of Flomax. Burning with urination would be bad. That would be like a sign of an infection. We have a PCA pump. The client is reporting nausea and vomiting. What do we want to do? And we had a hip surgery.
Yeah.
Let's see. So it's auscultate bowel sounds. So this is one of those scenarios where we want to assess further before we do something. We might give an antiemetic. So in the nursing process, we want to know, are there bowel sounds? Are they passing flatulence? And determine more about the cause of the nausea. So we know that nausea can be a side effect of opioid analgesics like morphine. So is it a side effect of the morphine, or is there something else going on here? So we just need to check that first. Okay, we have 4 clients and we have 4 lab values. Which of the following lab values is a manifestation of acute kidney injury? Let's see. So exactly, our bun, is 10 to 20, so we're within range. Creatinine is high at 6. Hemoglobin normal, potassium normal. Yes, everybody got it. It's our teamwork. Okay, we are performing a monofilament sensory assessment of a client with diabetes. Which of the following complications are we monitoring? or which of the following complications? What are we looking for? We're trying to test if the patient has what? Great. So we want to test sensation with monofilament sensory assessment. Makes sense. We're checking for neuropathy. We talked about how they have decreased feelings, so makes sense, right? Nephropathy, we're not concerned about their kidneys. Radiculopathy would be like referred pain. Retinopathy would be visual tests. So the sensory assessment that we're looking for tests for neuropathy. Okay, carbohydrate intake needs when exercising. Okay, so which of the following is a 15-gram serving of carbohydrates? Exactly. So a cup of milk. That's a really common thing that you're going to have available to you in the hospital. There's those little milk cartons like when you were a kid and you were in the cafeteria. So we can give a cup of milk and give 15 grams of carbohydrates. Milk is a good choice because it also has some protein in it to kind of stick with them a little bit longer. Okay, we have a patient that has a femur fracture. We're suspecting, I think, what was it? Somebody emailed me about this one. Which of the following findings would the nurse identify as an early manifestation of fat embolism syndrome? Lots of B. Okay, hypoxemia. Yes. Maybe that was a different question. A is later. Okay. Janelle, you know what I'm talking about? I think there might be a glitch in another question about the fat embolism. But yeah, we're concerned that we have a fat embolism that would go to the lungs. And so we're concerned that increased respiratory rate, shortness of breath, and low arterial oxygen level are bad. So hypoxemia would be a warning sign that the patient might have developed fat embolism syndrome. Okay, we're taking a creatinine level. The patient wants to know what we're checking with the serum creatinine. What is that for? Yeah. It's testing your kidney functioning. Exactly. That's what we want to know. Yes, we got that one. So if we're going to give them IV dye, we're going to check it and we're going to explain to them, we're going to check this to see how well your kidneys are functioning. Okay, which of the following types of medication therapy is a risk factor for developing osteoporosis? D. So that is correct. Okay, we're going to measure the TSH level. Which of the following statements explains the purpose of this test? Yeah. So this lets us know how much thyroid stimulating hormone is being released. And this is one of those complicated things you have to get straight in your brain, where too much thyroid stimulating hormone means hypothyroid. So the thyroid is overacting by producing more and more TSH. So high levels of TSH lead to, or are indicative of hypothyroidism. I always have to think about that one because it's opposite of what you would think. Okay, we have an intercapsular fracture of the right hip, and we want to teach about Buck's traction. What do we want to teach about Buck's traction? B. Yes. So correct. Traction helps reduce pain. It helps reduce muscle spasms, and what was the other thing? It's also going to help immobilize the area. So when we talked about our fractures, and I said, if you don't remember anything else, we want to keep that fractured area in alignment and immobilized. So we're going to put it into traction for that. Okay, our client has mixed edema. What findings are we going to expect?
Hi, Mom.
Hi, Estelle.
Are you in class?
Both for B is correct. So we would expect to see facial edema. A severe mixed edema is a severe form of hypothyroid. So we would expect non-cutting edema everywhere, especially around the eyes, hands, and feet. Okay, we have a patient with DKA. Ooh, their blood glucose is 925. That's bad. A nurse should anticipate which of the following prescriptions. Yeah. No. IV bolus, yes. So eventually we'll give D5 half NS, probably with potassium, so D5 half NS plus potassium, when they've reached below. But in a crisis of 925 of sugar, we want to give boluses to bring that down. And restore volume, yes. Okay. We want to teach about preventing osteoporosis. Which of the following statements by the client indicates need for further teaching? So which of these is not true about preventing osteoporosis? D. And that is correct. So sodium isn't really related to this. Caffeine, excessive caffeine is a risk factor for osteoporosis. Okay. This was a correct statement. I will reduce my intake. Okay, so we don't want them to do that. We want them to have a diet of vitamin K rich foods. Okay, we're going to begin a program of regular physical activity. What recommendations do we want to make for an older adult client who has osteoporosis? It's B for this one. Yeah, so we don't want Mima to do anything too crazy, like riding a bike sounds like a terrible idea. High impact aerobics, we don't want high impact. I want Mima to actually probably go swimming, but walking briskly, that's great. We're gonna promote weight bearing to help with the bone strength. So walking briskly is a good way to maintain the bone mass. Strength training doesn't really do anything. Okay, we are in the oliguric phase of acute kidney injury. Which of the following information are we going to include in our teaching? So which of the following is true? So an oliguric phase, if you remember, oliguria is basically a little bit of urine output. So we're having less than 400 mils in 24 hours. That's really not a lot for a whole 24 hours. So the kidney is still kind of in shock, it's injured, and we are within the oliguric phase. This would be the recovery phase. This would be the diuresis phase. Yeah, recovery phase. So if you know what oliguria means, then you got this question. Okay, we have a client that had a below the knee amputation. Which of the following findings would be a complication? I feel like we did one of these together. Yeah, exactly. So pitting edema, that's bad. We don't want that. The purpose of that ACE bandage or the compression bandage on the stump is to control that edema, and so it's not doing its job. So that would be a complication, and we would want to take it off and then rewrap it. Okay, what is a manifestation of hypoglycemia? So shaky, nervous, sweaty. Those are what we're looking for as your hallmark hypoglycemic reaction. Yeah, sometimes patients have a different thing. Like they know that if they feel a certain kind of way that they're hypoglycemic, but your hallmark symptoms are going to be that sweaty, nervous, and shaky. Okay, sorry, my daughter decided it was the best time to sweep in my room. Okay, so we have regular insulin via a sliding scale. We administer the correct dose at 7:15. When do we want to give breakfast? So how soon after giving insulin do we need to give breakfast to our client? Yes. Oh, incorrect. 7:45. 20 to 30 minutes. Interesting. Okay. Now we know. I swear I've seen different ranges in other places. Okay. For our purposes, we will go with that. We have type 1 diabetes. Which one of the following statements is true about diabetes? Take my blood sugar after meals. Allows me to eat ice cream and vegetables. I'll go with D. Before meals, no, sweetie. It shouldn't make you hypoglycemic, but we do need to be careful with exercise. It does drive that blood sugar down. But no, we're not concerned about that. And then we're going to give, so this is what we were kind of talking about earlier. So abdomen is fastest for absorption. Other areas of the body can take longer. Definitely be, yeah. My boyfriend in college had diabetes and he ate a lot of Oreos. So he thought that was what the insulin was for, I guess. Okay, we have a client who has BPH. Which of the following medications? So which of these medications treats BPH? Do you guys think B? That's correct. And this is Proscar. And so if you remember these medications, something that we have to be careful with is pregnant women cannot handle these medications. So you always want to wear gloves when you touch the Proscar. Oh my gosh, my phone's blowing up. Okay, so we have a client, they're gonna have a hysterectomy. and they decide to delay having surgery for several months, what are we gonna say? See, exactly. You guys learned from our last one. So this is a classic question that you've seen this before, right? We don't want to assume why. We want to find out more about it. Could be money issue, could be they have a sick relative they're taking care of. There could be all different kinds of things. So until we know what that is, we're not going to have a reaction. We're not going to have a response because we don't know why. So tell me more about that. Okay, risk factors for osteoarthritis. So which of the following are risk factors for osteoarthritis? Bacteria, interesting. Not bacteria, not diuretics. Aging, for sure. Obesity, we have more pressure on our joints. Smoking, we know, is a risk factor for osteoarthritis. Femur fracture. Now we're in skeletal traction. Okay, I feel like we did this one together too. When can we take the weights off the traction device? Okay, and it's B. So we don't want to take it off unless it's an emergency because, again, hopefully you remember this, with our fracture, we want to keep it in place and immobilized. So we don't, when we take the traction off, then we're possibly displacing that fracture and we're undoing the pain control and the muscle spasm control. So unless it's like an absolute emergency, we don't want to take it off. But if they're dying, if they're coding, and we need to get our equipment in there, and we need to work on them, then that's going to be second priority. But that would really be the only reason. And really, when we're doing an X-ray too, we want to see the alignment of the bone, so we don't want to take the traction off. That would be against our goals. Our patient has a prescription for furosemide, which is Lasix. Which of the following statements indicates an understanding of the teaching? D. Exactly. And so breaking this down, we know that furosemide is a loop diuretic, and so that's going to drive our potassium down. So we don't want them to do that. We want them to increase their potassium intake. We don't want them to limit their fluids because this is going to pull fluids off. We don't want them getting dehydrated. Diuretics are one of the first line treatments for hypertension, so we expect the blood pressure to go down. And so by process of elimination, and because we know, we want to limit sun exposure and we want them to wear sunscreen because they can become photosensitive on that medication. Blood gases again, chronic kidney disease. This is like a repeat of the other one. So which one do we think it is? Yes. So again, we have metabolic acidosis. So we know we have acidosis because our pH is low. Our normal pH value is 735 to 745. So when we're lower than that, we are acidotic. Our CO2 is a little bit low. So we know our acidosis is not from our CO2. Our CO2 is not elevated. So it's not respiratory acidosis. Our bicarb is low. So when our bicarb is low, that's also going to drive our pH down. So if our bicarb is high, that makes the patient alkalotic. When it's low, it makes the patient acidotic. So when we have chronic kidney disease, we're expecting the kidneys to not be producing that bicarb and helping regulate that acid-base balance equation. Okay, we're teaching about fluid restrictions. Which one of these is true about fluid restrictions? What do you guys think? Couple guesses for D. So it is a B. We don't want to consume most of the food during the evening. We want them to kind of keep it balanced throughout the day. Make a list of their favorite beverages, kind of plan out what they're going to drink during the day. Sounds like a good plan. We want them to use a small container. So if you think about it, if you put a little bit in it would be a little bit in a large container, or it would look like more in a smaller container. So we're going to kind of trick the brain and make them think that they're getting a full glass, right? So we're going to put it in a small container. And ice cream is considered a liquid. So anything that is liquid at room temperature counts as a liquid. So even things like Jell-O, ice cream, popsicle, those all count toward our fluid intake. Okay. Which one of the following teachings is correct about osteoarthritis? Guesses for D. Okay, I was thinking A. So we can do either heat or ice, whichever one feels better for them. I know. So cold is going to help reduce inflammation, kind of decrease the nerve ending reception of pain and the inflammation. Heat kind of helps relax that joint. And so either one or both might be better at different times. So they can use both. We're going to use Tylenol. We want them to have physical activity to keep that joint mobile. Okay, we don't want them to put pillows under their knees because they can develop flexion contractions. That's why it's not D. A nurse misread the client's morning blood glucose level as 210 instead of 120, and administered the insulin dose appropriate for the 200 range before breakfast. Which of the following actions is nurse priority? What do we want to do first? Most votes for B. So yes, it's definitely, we're going to want to probably administer this, but before that, we're going to check and see what their sugar is. So when we realize, oh my gosh, we gave too much insulin, I need to know what my patient's blood sugar is. It might be fine. Maybe they needed that much. Who knows? So we're going to check. And we're definitely going to keep an eye on them and watch them over time for hypoglycemia. Probably a good idea to administer a snack. We have to make an incident report whenever there's a med error. So yes, we're going to do that. Depending on your facility, you may or may not need to directly tell your manager. They're going to see the incident report. They're going to find out about it anyway. I would also add on there, notify the provider after we address the patient's needs, okay? So should that happen to you in real life, you're going to want to notify the provider. If you have diabetic ketoacidosis, what are we going to expect? B, is that for this one, Brandon? That's correct. So we would actually expect hypotension. So if you remember our patient that came in, their blood sugar was 925 or whatever it was, we're giving fluid boluses to help flush that out and to help rehydrate. Acetone odor, people say juicy throat gum smell to the breath, and it comes from the excessive ketones. Cheyne-Stokes breathing means you're about to die, so hopefully that's not it. Blood glucose level below 40, that's opposite. We know that's not right, because we have ketoacidosis. We know our sugar's super high. It's not too low. So this, we know we can immediately rule that one out. We want to prevent urinary tract infections. Which one of these lets us know that we need to do some more teaching with our client? I'm just gonna go ahead and, okay, good. Everybody knows ever since they're like my 3-year-old that we need to wipe front to back, okay? Should be an easy one. We have an EGD. Which of the following assessments is our priority? I'm gonna actually go with C. So pain will do it, but if we can only do one, I need to know if they have their gag reflex. So whenever we do an EGD, that's when we're doing the scope down through the mouth way. And we're going to numb the throat to do that so that we can pass the scope down. So whenever we numb the throat, it's possible that the gag reflex is not present yet as they're waking up. So we want them to be able to protect their airway and not aspirate any secretions. So our biggest priority is making sure that gag reflex is back. And if it's not, then we're going to treat them accordingly. We will address their pain. We will address their nausea. Level of consciousness, yeah, but I'm more concerned about their gag. Okay, we have a lower arm fracture. Which of the following is a symptom of impaired venous return? So which one of these is bad? Well, bad, but what do you guys think? Yeah, exactly. So a bounding pulse is not consistent with impaired circulation, right? That doesn't make sense. Acute pain, maybe. Ecchymosis is bruising. So bruising doesn't go with impaired circulation. That's from like trauma to the tissues. So increasing edema makes sense because remember, as we have less blood flow to the area, our edema starts to increase. Or a patient feels shaky and feels like they're having palpitations. Oh, we checked the sugar, it's 48. What are we gonna do? Okay. Yeah, so we talked about milk earlier and we would wanna give 8 ounces. So a cup, close, Kaylin. So remember a cup is 8 ounces. So we could have given that, but 4 ounces isn't enough milk. Diet soda, doesn't have sugar, it's not gonna help. A teaspoon of sugar, no. Yeah, Michelle?
So on the milk, I thought D too, but I heard you say that it had to be 8 ounces. But does it matter if it's skim milk or full fat milk or low fat milk? Does that make a difference?
No, because you really want the sugar from it, not the fat content. So it doesn't matter which milk. Does that make sense?
Yes, thank you.
Okay. So yeah, they kind of tricked you with this because you're like, oh, milk. The other one was milk, but they wanted you to recognize that it's a cup of milk, so 8 ounces. Graham crackers is 15 grams. We could also do 4 ounces of fruit juice, 8 ounces of milk, 3 teaspoons of sugar, not 1, 3 graham crackers, or a glucose tablet. Okay, and then we'll recheck in 15 minutes because like we said in our other question, we gotta let the body have time to respond to that. Okay, so which of the following increases the risk for developing type 2 diabetes? Just gonna kind of start powering through some of these. Okay, blood pressure. I went with abdominal girth because, you know, increased abdominal girth does, they're saying 35 or more. Increased blood pressure is going to put you at a higher risk for diabetes. Okay, which one of these is criteria for diagnosis of diabetes? So hemoglobin, we want our hemoglobin that low. We aren't high enough for that. Fasting blood glucose 155 is too high. Okay, so femoral head fracture, we have a long bone fracture, and we are concerned about fat embolism in that scenario. Okay, so some people do take herbal products, like we talked about when we talked about, I can't even think, low estrogen, but there's no real scientific backing. They might take it. They just need to make sure it doesn't interact with anything else that they're on for prescriptions. But it's not backed up by research. Okay, what are the manifestations of hypoglycemia? Okay, so we've kind of been over this a lot of times. So I'm trying not to take up a ton of your time. I'm trying to kind of power through these. Diabetes, what's a manifestation again? So here we are, cool, clammy skin. I swear you guys better not miss that if that's a question on the exam. If it's cool and clammy, please pick hypoglycemia. Okay, hand tremors. Okay, we got 60. We're gonna give 15 grams. 60 is low, but it's not an emergency, right? So like if we get a really low reading, we're gonna be a little bit more aggressive than giving 15 grams of carbohydrates. So like if it was 30, we're gonna be doing more aggressive measures than just a snack, right? Okay. We're gonna collect a midstream urine. How do I do that? Let's see. Okay, so whenever we're doing midstream urine, we're gonna instruct the patient to urinate a little bit to clear out the urinary tract, and then they're gonna pee in the cup. We are teaching about chronic kidney failure, and we're gonna plan a low protein diet. Why do I have to be concerned about protein? What are we gonna say? Okay, so we want to basically decrease the amount of broken down products from protein into the urine, or into the bloodstream, I'm sorry. So we want to have a low protein diet. And stop me if you guys have a question. I'm just gonna, like I said, I'm powering through because I don't want to take up too much of your time tonight. Okay, we had an abdominal hysterectomy. Which of the following information should we include in our teaching? Okay, so we know that it's this. So again, just like our moms that are going home, we want them to wait at least 4 weeks, 4 to 6 weeks to resume sexual intercourse, just to let the body heal. Okay, we got a subtotal thyroidectomy. We have a tingling sensation on the hands, feet, and around the lips. What are we concerned about? Ooh, it's this one. Okay, this, I have no idea how to say this, I'm sorry. Chvosek. And so these are all symptoms of hypocalcemia, and somebody decided to give it a fancy name, and it's Chvosek. I don't know how to say it. Okay, urolithiasis. We have stones. Which of the following is a risk factor for stones? Oh, no. Yes. Oh, I missed it, really? Family history. Interesting. Okay. I didn't know that one too. So family history is a risk factor for stones. That's true. Dehydration also is not good. So that's why I went for diuretics. Sorry, I got that one wrong. Chronic kidney disease. Why can't I just take the antacid Magaldrate? My husband has at home. Aluminum hydroxide lowers which of the following? What do you guys think? Honestly, I have no idea. Just gonna go with A. So I know it didn't affect potassium, magnesium and calcium. We know we're giving like milk of magnesia, or not milk of magnesia, things that have magnesium in it for antacids. A lot of them have calcium in it. So this is like real time. How do you take a test? I had no idea what that answer was. But breaking it down, I know it's not potassium. Magnesium and calcium are in antacids most of the time. So I guessed phosphorus, and I was right. So that's how you do it. Okay, we have a prosthetic limb right below the knee amputation. Blah, blah, blah. What are we going to teach them? No, yes. So we did this one together, if you guys remember. We want to dry it completely so that there's no wetness and no chance for bacteria to accumulate. And when it's dry, it's not going to slip as much. So we're going to have less risk of skin breakdown. Let's see. Really? Okay. I kind of have to disagree with this one. Oh, you guys picked C? Okay, good for you. I would have missed that. In my mind, I have a patient that had nausea and vomiting for 24 hours. I'm more concerned about their intake and output, but maybe by monitor intake and output, they mean continuously. So pain medication, good job. Which of the following is appropriate? The bond is 32. Okay, well, those are still high. No. Check specific gravity. What do you guys think? So our bun and our creatinine are still high. So nothing really is telling me that I need a culture and sensitivity. This is not correct because those aren't in range. Because these aren't in range, I don't want to decrease my IV fluids. I'm still showing dehydration in my labs. So I'm going to check the specific gravity to see if indeed they are dehydrated. So a higher specific gravity, the more dehydrated. Just kind of another data point. Okay, diabetes insipidus, dehydrated. No, it's the top range, Patrick, is usually 1. And I don't think it's 0.8. I want to say it's 0.4 to 1. Okay, so we're going to expect diabetes insipidus. We know that they're having excessive urine output, and we're going to expect dehydration symptoms. Uh-oh, we have pelvic fracture. Okay, makes sense. Okay, so we have a fracture in the pelvic area. Hematuria is blood in the urine. Kind of makes sense, right? We could have internal bleeding, and we would definitely want to monitor for that. We're really concerned about with pelvic fracture. We're really, really concerned about all the abdominal organs and whether or not they're also damaged. So we want to monitor for that. I feel like we did this. This is different. Oh, secondhand smoke. Wait, that piece. Okay. So sedentary lifestyle we know is bad. Aging, just part of the normal. Yep, Kaylin, good job. Part of the normal aging process. Caffeine is bad for our bones. Secondhand smoke, also bad for us. Not as bad as smoking yourself, but we still don't want to be exposed. We have a fiberglass cast. Any worsening or unrelieved pain? I'm gonna go with this. Just no. We don't want to put anything under the cast. Worsening unrelieved pain underneath the cast is concerning, right? Because we could have edema and things going on under there. So we definitely want them to report that. They're gonna use their leg with limitations. So we want them to still move the leg. Okay, we have a UTI. What's a risk factor for a UTI? And it's going to be diabetes. So bacteria loves glucose, and in diabetes, we're going to have increased glucose in our urine. So that's creating a situation for those bacteria to proliferate and grow out of control and grow into a infection. Also, high risk for yeast infections in those patients. Yeast love that sugar, and they are highly susceptible to yeast infections. Okay. I'm gonna go for this one. So it's really important if you see anything on your exam about kidney stones. Also, always remember for kidney stones, we want to know what it is made of because that's going to dictate how we treat the patient. So we want to strain the urine and we want to get a stone if we can. This one has calcium oxalate is what makes up the stone. So we don't really want them to take in a bunch more calcium because their body is forming calcium stones. Drinking 3 liters of fluid is what we talked about earlier with kidney stones. It's going to flush everything out, keep the urine nice and hydrated so that, nice and diluted, there we go, that's the word, so that there's less chance of a stone forming. And then we know we want them to be on a lower protein diet and restrict calcium to 3 servings a day. Okay, we're gonna have a below the knee amputation. How do we know about the prosthesis? Let's see. Oh my goodness. Special exercises. So we're gonna prepare that stump in order to accept the prosthesis. Okay, we take furosemide. What's the priority? And it's our potassium. This is bad. It's way too low. We're teaching about osteoarthritis. I'll look at this one. Echinacea is not something that is backed up by research for arthritis. We would want to maybe put heat to help the joint move better. Recommended body weight. So in osteoarthritis, we don't want extra pressure on our joints. And then purine is not related. This is more concerned for gout. I feel like we already had this question, yeah? So thyroid hormones. Are we getting repeats? Ooh, okay. Chronic kidney disease. A, B, E. Wait, C, A, B, and E. I feel like I'm right. Okay. Protein, we know. Calcium, that would be, if there were stones, we would be concerned about that. Calories, not really related. Phosphorus and sodium are both at risk for building up when we have kidney dysfunction. Also, this great. See? See, it is. That's right. Good job. Okay. Good job, Patrick. So that was on our other exam. Remember, in older patients, we are concerned about UTI if we see confusion, especially in the older adults. Okay. What do you guys think? So with DKA, we're always using regular insulin. Okay. We don't use the long-acting ones. We're going to be using just regular insulin, and usually we're going to give it IV. Michelle says B. So take the medication with a meal. Yes, A. So kind of easy to remember because we're taking metformin, just like insulin, we're going to take it with a meal. This one, because it can mess with your stomach and cause stomach upset, and it's going to help the medication absorb the best and prevent hypoglycemia. Okay, foot care. Oh wait, nylon socks. Yeah. Okay. They need to be really, really careful trimming their nails. And honestly, I think most of the time are referred to go to podiatry to trim the nails because we don't want to have any injuries. Buying new shoes late in the day is going to ensure that they are going to fit later in the day and they're not going to be too tight because as we go through the day, our feet tend to swell, right? Nylon, I almost picked this one because I was like, oh yeah, clean socks every day. But we want to wear cotton socks. We don't want to wear nylon socks because that increases sweating and that can increase the friction in the socks. So we want to wear cotton socks and we do want to wear a clean pair every day. And we don't want to put heating pads on diabetic feet. That's a no-no. What do we think if an older adult is dehydrated? What do you guys think? Definitely not this. Definitely not this. You guys think D? I could have gone for either one. Sunken eyeballs. But I feel like sunken eyeballs kind of look protruding, no? Okay. We would expect hyperthermia, sunken eyeballs, decreased blood pressure. When we don't have enough fluid in our body, our blood pressure is going to be low, right? It's not going to be too high. Furrows on the tongue. Our tongue is dry. Mucous membranes are dry. Furrows. Okay, finasteride. Ooh. I'm guessing B, and I am incorrect. Decreased libido. Okay. I didn't know that. High in potassium. Ooh, okay. Bananas for sure. What do you guys think? A, C, and D? C and D. Let's try A, C, and D. No. Green beans, no. Ah, I had tomatoes and I took it off. Bananas for sure. That's like your classic one, right? For potassium. Asparagus does not have potassium. Raisins are high in potassium. What is it that I was thinking about? Raisins have something else. Okay, so tomatoes, bananas, raisins. Tomatoes, bananas, raisins. Okay, we're treating osteoarthritis. What could be an adverse effect? Vote for A, I vote for B. So B, GI bleed, maybe it's that, yeah. So black tarry stools are GI bleed. This medication can cause gastric irritation. So if we see a black tarry stool, that means that we're having bleeding in the GI tract. Uh-oh, we got constant leakage of small amounts of urine. This bladder is distended and palpable. What is this? Oh. Constant leakage of small amounts of reflux. Okay. Whew. So stress and incontinence we talked about, when we have stress to the body, we're losing amounts of urine. Urge incontinence is when you gotta go. It just might slip out on you. Overflow incontinence, we know when the bladder is distended and palpable that we've got urine backed up, right? And small amounts are just kind of leaking out because it's overly full and the patient needs to urinate, but they're not able to get that going. So things like BPH, we might see this overflow incontinence. Reflex incontinence associated with neurologic dysfunction. We're almost there. Yeah, it's overweight. Okay, so no. Balance the scale at -2. I don't know what that means. So we don't want to do that. We want to do it at the same time. -2. I don't know what that means. Okay. That was really confusing. I didn't know what that meant. So like I said earlier, we talked about always using the same scale. We want to be consistent. If we start weighing them on the bed scale, we need to keep weighing them in the bed scale. If we use a standing scale, then we need to stick with that. They need to wear about the same amount of clothing. If we're doing the bed, have the same amount of things on the bed, however many pillows, however many sheets. We always had like a standard amount of things that would be on the bed. It was like a pillow, a sheet, and a blanket. And so that was it. And that way it was consistent and everybody knew what was supposed to be on the bed. We want to do it at the same time. And then we don't want to weigh their urine. We want to weigh their actual weight. So that is the only answer that made sense. Okay, let's see. Ooh. That sounds bad. So peritoneal dialysis, that's when the patient's going to have the solutions actually sit in the peritoneal space and work by, what am I trying to say? I can't think of words right now. Passive, there we go, passive changing of the electrolytes, and it might be a little bit uncomfortable. Colder dialysate can also cause the discomfort. We might see a little bit of blood-tinged dialysate, especially when they first start treatment. Leakage during inflow, wouldn't be as concerned about that. Purulent dialysate outflow. That sounds real bad, right? We have pus coming out of the peritoneal space. That's bad. We have to be really, really careful with the peritoneal space because this can make the patient really, really sick if they get an infection there. So purulent dialysate, bad news. We need to notify the provider immediately. We have Lispro insulin. What do you guys think? I feel like we got burned on that other one with the 15 minutes. I swear we chose 15 minutes on the other one and it told us 20 to 30 minutes. It's frustrating. We chose 10. Okay. 15 minutes makes sense. Oh, okay. Maybe so. So 15 minutes before the meal. Polyuria, that would be hyperglycemia. We want to check 1 to 3 hours, not 4 hours, because we're going to peak at 1 to 3. And this is confusing. This is confusing because it's like saying maybe we would do it. But this is the most correct, I guess. All right. We're doing a breast self-exam. How do I know? I don't have to, I don't know. I feel if I'm okay, yes, yes. Yeah, this is hard because we can do that. I'll hear for that. So this is true. I remember like there used to be I don't know, a campaign or like a awareness thing that asked women to check their breasts in the shower. So you can stand. It would be somewhat normal to feel a firm ridge in the lower curve of the breast. You might be feeling like the rib. You want to press firmly enough to feel if there's any changes. When you don't have periods anymore, it's not going to be hormonal changes on the breast due to menstruation, so you can check at any time. And we want to make sure that they check all the way up into the axillary area as well. Polycystic kidney disease. Lily's being bad. I'm gonna flip blank pain. Polycystic kidney disease, blank pain, like we said earlier, is going to be the kidney area, so it's an expected finding. Okay, yes, yes, no, yes. Retinopathy and neuropathy. So this is kind of a complicated one because yes, we want them to do that. Yes, we want them to do that. No, we don't want them to do that necessarily. But maintaining stable blood glucose levels is going to prevent complications. So even though, yes, we want them to have an eye exam, that's not going to prevent complications. Or examining their feet, that doesn't kind of prevents complications, but actively preventing complications is keeping blood glucose in range. Oh, it's tricky. Okay. Okay, so diabetes insipidus, remember, we're having a lot of urine output. We want to be monitoring our specific gravity. Okay, last one. We have an indwelling catheter. Which of the following actions do we want to take to prevent infection? Okay, so we don't want to replace the catheter unless we need to. Good job, Michelle. We don't want any kinks or twisting in our tubing because that can block the flow of the urine and make it back up. We don't really want to irrigate it unless we absolutely have to because of an obstruction, because we're disturbing the sterility of the system. When we're going to clean with soap and water, we do want to do pericare, but we don't need antiseptic solution. That sounds kind of painful. Okay, so I really hope that was helpful. Sorry that took a lot of time. But I'm sorry I kind of missed you guys too. So I hope this was helpful. Good. Hi, Carly. You're welcome. Yeah, of course. All right, have a great night.
Professor,
Good luck
are you
tomorrow.
able to post the exam on Exemplify for us to download?
Yes, thank you for reminding me. I'm going to do that right now. I was trying to before, and sometimes what it does is not let me open in Chrome. So thank you for reminding me. I will do it right now so you guys can download. 50, Kaylin.
Thank you.
You're welcome. Okay, good luck.